It's 1:01 and Holly Horner, welcome. Oh no, she's in the lobby. Let her in. Holly Horner, welcome. It's good to see you here today, doing some learning.
Yeah, look, I thought I might come along and say hi. I don't talk to you often enough, Michelle.
No, you're true. I'd say I haven't seen your email in my inbox, but actually there's still one sitting there that I'm waiting on some logic tomorrow to then come back to you about. So you're still there. But good to see that you find some time to dial into a webinar. It's important to learn, Holly. It's important to learn.
Yes.
Let's get started. Good stuff. Happy Tuesday, people. Webinar 4. It's the last one for the year. Don't be sad. It's going to be okay. And the content is going to get you through to next year. And then you're just going to be so excited to see us again. Beyond compliance, we're pushing the boundaries from compliance to workforce capability. Zoe is going to run the webinar today. I know you're all sad. It's not me, but it's okay because this is compliance stuff, which we all know Zoe's way better at. Who's pressing the buttons? Next slide. Oh, do I have control to do that? Thank you. Welcome to country. So I am acknowledging country, not welcoming. Apologies there. I'm a Wongal country. We play, we work, and we live here, and we're grateful for that. I show my respect to the elders past, present, and emerging. I know Zoe's on different country today. I can't Wurundjeri? Yes. So we pay our respects on Wurundjeri country as well. Next slide. Who's pressing the slides? Is that you, Austin? A little bit delayed. Whoa, too fast.
Me.
Go back.
Sorry.
Oh, Zoe. What was the slide?
I've got one job. It's to talk and press slides.
What was the slide before this slide? Or did you go 2 slides and now you've gone back one?
I
saw an extra slide. Oh, okay. You must, maybe you went fast forward and went back.
Yeah.
Great. Yeah, good. Okay, all good. Okay, so let me look. You can see Zoe, gorgeous face, cooking French. We don't care about that stuff. What we care about is that Zoe is a critical care RN who's been with Osmed for so long. We're pretty sure she has tenure. In her 10+ years here, she's done everything from writing a master's thesis on CPD impact to setting international standards for nursing education, because why not? I don't have time. She has the energy. These days, she's the mastermind behind Osmed's accredited provider unit, keeping it the only Australian team with a shiny ANCC distinction for 4 consecutive cycles. I'm a credit girl, but Zoe's all about distinctions. She's also our in-house expert on clinical governance, risk and compliance, which basically makes her the coolest person you'll ever meet who talks about regulation for fun. And there's not many of those people, but Zoe is the top of the pack. So let's welcome Zoe, leading our webinar, last one for 2024. Thank you, Zoe. Yay!
Thank you. Thanks, Michelle. Thanks, Michelle. Hello, everyone. It is so nice to see you. Thank you for on the 10th of December joining us today. I'm gonna make this great for you. Because I think we've got a really, really exciting topic to explore today. All right, so what are we covering today? Well, we're as Michelle said, we're moving from compliance into capability space. So few objectives. First, I just want to introduce a little tiny introduction to a capability-based approach to training and learning. Then I wish to unpack the concept of workforce pressures. We have all spoken about them, we've all read them, we've all seen them, we all feel them, but I want to unpack what exactly does that mean. Then move into thinking about how those pressures impact our organisations, but critically move into explaining, defining, recognising the importance of workforce capability, and I'll end with just some non-training tips, strategies, just to highlight that workforce capability is the antidote to these workforce pressures, but it is more than just delivering training and certainly more than just delivering compliance. So jump straight in. You know, we know compliance training is valuable for 2 reasons. It can mitigate risk. So for the topics that it is required, it can actually mitigate risk. And then the second reason why we do it is because if an auditor shows up and asks for evidence that, if a risk happens and an audit takes place, we can actually demonstrate that the organisation has made all reasonable attempts to mitigate that risk. So we have evidence. Now, that works when we have, let's say, 10 topics, 10 big key risks within an organisation that we want to mitigate. But what we're seeing is regulation move to more of an outcomes-based approach. So an outcomes-based regulatory model, such as the strength and standards, has 34 audited outcomes, and we assessed 142 plus implied knowledge, skills, attitudes, or competency requirements. When we talk that number, mandatory training is not fit for purpose. We can't provide mandatory training on 142 plus items. So that's why we are talking about moving to a capability-based approach to training and learning. So very, very timely that we start to look at this. Very briefly, what is it? I just want to think about it as three things for now. We'll dig deeper as we go. It's more personalized. Compliance training, standardized. Capability-based training, very much so it's personalized. And we're looking at not just providing evidence that particular training has been done or completed, but we're looking at providing evidence that the initiative has actually built knowledge, skills, attitudes, and competence. So much more than just standardized training. And the third facet to a capability-based training and education approach is confidence. Yes, to the learner, but more so for the organisation. A capability-based approach to training and education actually affords an organisation with the confidence that they can deliver and grow the core value of their service. We're seeing a lot of growth, a lot of movement, a lot of amalgamation. So building a capability-based approach to training and education actually genuinely leads to improved quality care provision by the staff. But it only works if it's done in a scalable way and if we can measure it. And that's where our strategy comes in. That's all I'm going to say for now. I'm just introducing very briefly why we're talking about capability-based training and education. Keep that top of mind as we work through. But I do want to unpack this concept of workforce pressures, all right? Presently, the terms workforce stress, workforce issues, workforce challenges, workforce pressure, they're now firmly rooted in the modern vernacular of healthcare. I feel for the past 5 years, certainly, we are hearing a lot of these terms. Think back to the last conference that you went to. How many times did you see a session that said, planning for the workforce of the future, or navigating workforce challenges, improving workforce retention? These concepts are very much front of mind at the moment, which is great. We clearly have some issues, but I feel like we're saying these things so much. We're hearing these terms, they somewhat become cliches. And I think that we've almost, forgotten, hang on, what's the exact issue that we're trying to solve for? Why are we talking about these things? If we double click down on workforce, what is it? It's three things. Hiring. Have we got enough people? Retention. Are we keeping them? And capability. Have our people got the knowledge, the skills, and competence to do their job? And are they competent? But that's still very broad, right? We're still talking at a high level. I'm trying to get a little bit more granular here. So let's rewind. Bit of a story. I know you'll understand exactly what is going on here, and it's COVID. And I think during COVID, these challenges, these issues, they were quite obvious, weren't they? We had nurses, care workers, clinicians dealing with very long hours, very seriously unwell patients and older people, shortages in protective equipment. We could all see and feel the stress of a very turbulent, uncertain, and a health system under pressure. If we fast forward to post-COVID, these workforce challenges, I think, were typically presented as a numbers issue, right? We then moved into talking about staff shortages in a system that was already grappling with the challenges of shift work and workplace stress. But the good news is that significant efforts are well underway to recruit more nursing undergraduates into programs. We fixed our migration issues. We saw, a lot of ongoing efforts to get back to pre-COVID numbers in terms of workforce. So we really put a lot of effort into making improvements to attract and acquire new staff. In fact, just recently, the AHPRA, so the Australian Health Practitioners Regulation Agency that regulates the 15 registered health professionals in conjunction with the boards, in their annual report released in October, they said there was a 2.1% increase in the registration. Now, we're looking at nurse and midwife data here, and that included approximately 1/3 of all registered nurses were overseas trained. So they reduced some restrictions around international nursing qualifications, and we're seeing new numbers of we're seeing new staff numbers increase, but we've still got a problem, right? Our workforce data in 2024, this is taken from AIHW, showed that within nursing, at least almost 10% of nurses and midwives every year are leaving. We're seeing dropout rates in the first 12 months of graduate nurse programs ranging from 2.8% and reported intention to leave the profession as high as 20%. I met with the general manager of learning and development at St Vincent's Health in Melbourne, so big public hospital in Melbourne, on Friday, and she said that from 2020 to 2023, 44% of their nurses that had more than 5 years experience quit. So almost half of their group of nurses that were experienced quit during 2 or 3 years. So we have a problem, right? We have a problem, but what is it? What is our problem? It is not a challenge. It's not an issue around staff shortages. It's a decline in the experience of our workforce. That is our issue, a decline in the experience of our workforce. And interestingly, this challenge actually has a name. So it is called the experience complexity gap. Now, rewinding again, back in December 2019, I a part of an international nursing education group, I got an email which featured an article on this exact problem. So this was released pre-COVID. So the authors of the paper wrote in the Journal of Nursing Administration that hospitals and health systems are facing a unique challenge within nursing, and that's this shortage of experience. So as our experienced workforce retire and our number of new clinicians enters, the overall experience across the workforce is declining, but at the same time, the complexity of care is increasing. Now, at the time, so in 2019, the authors stated that this gap will likely widen without intervention, which would jeopardize the quality of care and patient safety. So 2019, December, what happened, of course? We had COVID. So this amplified all of the factors. Now, we're going to tap into this a little bit more, but what I want to think about is what happens when we lose experience. We also lose capability. So at the time where there's greater expectations, we're actually having less experience and less capability. So it's exacerbated, right? We haven't got as many experienced clinicians within our workforce to teach and grow the capability of our new staff coming through. And so our workforce experience and our workforce capability is declining at the same time that the complexity of care continues to increase. So what is our goal, right? Our goal is to clearly close or narrow this gap, because we need a workforce that is more competent and more capable to match the more complex needs of our consumers. So we need to bring up the workforce experience. We need to build that workforce capability. We want what we can do within our organizations, our capability, to match what our consumers or our clients need. So if I summarize the underlying issue, I think about it as a supply and demand issue. On the demand side, we've got greater demand for services. Think of your own services, the amount of people knocking on your door, wanting a bed, wanting a package. We've got greater demand for services. We've got increased complexity of those care requirements. So think of aged care. You know, I know we've got a broad audience here, but aged care, I think, is becoming a subacute care. You know, we're seeing greater transitions of care to and from acute care, rehabilitation, short-term care. And we've got higher expectations of quality of care for consumers. Right now, that's a good thing, but it is placing more demand on our services. And we all know that we have tighter regulatory requirements to meet and to maintain compliance with. So on the demand side, we've got more people wanting care, but greater complexity of care, greater expectations of care, and a greater need to be compliant with those expectations. So, you know, painting the problem here, right? Now, if we think what's happening on the supply side, we have higher exit rate of nurses. Now, I put nurses here. I know our workforce is more than just nurses, but there's very clear data on nursing workforce, and I can't find a similar, you know, strong data point for, let's say, you know, the care workforce within aged care, for example. So data points today are nurses, but I'm confident that this matches, you know, what we're seeing in non-nursing roles. So we've got a higher exit rate of nurses. People are leaving. We have more influx of novice nurses and early career staff, so at the beginning of their career. As I've mentioned, we have the decline in the average experience of staff. And at the same time, we know we've got burnt out staff that, you know, undergo issues like moral distress, but they're not working to the full scope of their practice. So we have some supply issues when we have some demand issues. Now, I want to go just a little bit deeper on this problem, because I think workforce capability, as I said at the start, we're talking about it a lot. We're talking about workforce pressures, but let's get to the root cause. You know, where did this challenge begin? Now, putting COVID aside for a moment and acknowledge that it exacerbated previous issues, I argue that workforce pressures actually come from good intention and even success. Why have we got greater demand for services? For healthcare, for aged care, for home care, and disability care in particular, because we've put funding there. Now, I know we never have enough funding, and I'm not making the case that funding should drop or be ceased, but we have greater demand because we've opened up more packages. We've put more funding into these services. Why have we got greater complexity? Because we have made such significant advancements over the past 2 decades. You know, we previously had incurable cancers, but they're now curable. We're keeping people alive longer. You know, we have greater complexity of care needs, partly driven by more complex chronic comorbidities. But we can't argue that that actually people are living longer and able to live longer with comorbidities and chronic diseases because of successes. And thinking about expectations of consumers, you know, what do our patients, what do our clients, what do older people want? They want, you know, rights-based, person-centered care, and they're demanding that. They're saying, I want that and I deserve that. And that's also a success, right? We've regulated that, and now people expect that type of care. So these are wins, right? These are all wins. We deliberately set out over the past 2 decades to achieve this, and we can celebrate, right? More people are receiving care. More people are living longer. You know, people are advocating for the high quality care, rights-based care, respectful care that they deserve. You know, so why aren't we celebrating? Why aren't we celebrating these wins? And I think because these wins still feel like huge issues to contend with, because they are. It is a big issue. We have environmental, microeconomic, macroeconomic, societal attitudes and population changes, which can't be overlooked when we're talking about workforce capability. They're not out of our control. I know they feel like it, but I think understanding them is really critical to the conversation and talking about the solutions that we want to implement. Okay, so does anyone have any questions? This is a big topic. Come off mute. I'm going to open up the chat. There's lots of AI assistants. Fabulous. Thank you, AI assistants. Any questions from part 1 or 2, you know, talking about defining this problem so far? Pop your hand up, come off mute. Does it make sense? because I'm introducing some new concepts.
Najila.
Najila, how are you? You're on mute still.
Sorry, how are you?
Great.
Lovely. I just had a question in relation to competency. I know that staff are completing all the units that we assigned them to on 10 point, on OSMED, but as the employer, how we can assess their competency as a result of completing those units? I know they are answering questions, etc., but it doesn't necessarily mean that they understood fully.
I agree. Yeah. Look, really great question. I'm going to stay high level for the moment. I hear that your question is, how do we assess competency of staff after, say, doing a mandatory training module or before doing it? That's a really important question that we're working with here at OSMED. I'm going to park it for now. We can give a bit of an update on our competency program at the end of the presentation, but I'll take the comment as something to come back to. All right. Just want to stay high level for now in terms of the problem. Thanks, Lisa. Great points. All make sense. That's good. All right. So I'm gonna keep going. So, but thank you for your comment, Najia. All right. So next part I know will resonate with you, because we're talking about how do these pressures, how does specifically the experience complexity gap show up in your workplace, right? Because as I said, we all feel certain pressures. We're all working on trying to solve certain pressures. And I think when we look at it through the lens of the experience complexity gap, you know, we can better look at what strategies we need to put in place. So the next part, you know, disclosure, it's pretty grim. Like these challenges are impacting quality of care. And I think they will resonate with you. So question is, how do workforce pressures manifest and impact on an organisation? The sad reality of how they show up is in a concept called incremental decline. All right, so it can be hard to see even when it's right in front of you. Now, what you might see is nothing obvious, right? The incremental decline is, as its name suggests, it's incremental. It's subtle changes, minor deviations from best practice, but they have a potential impact to become systemic issues, resulting in, yes, non-compliance, but potential or actual harm if unaddressed. So how these pressures, how these challenges, and specifically the experience complexity gap, you know, you might see subtle signs of slippage. So, you know, non-compliance rarely begins with overt negligence, right? Instead, it emerges through very subtle but repeated minor deviations from best practices. Shortcuts, workarounds, quick fixes, you know, we're doing that with good intentions in the name of efficiency. But overworked staff can cut corners, even just once, you know, we're not doing it often, but just once. But we'll get a subtle, very subtle cultural drift from best practices. So best practices used to be the norm, and then over time that becomes, well, it's good enough. And that's the way that we've always done it. So very subtle changes over time. We have leaders that may unknowingly deprioritize excellence in favour of immediate operational budget balancing, immediate compliance wins, and we get a gradual erosion of standards. I did acknowledge it's grim, but I'm calling out what we can see. So what happens when experience declines in a workplace? Well, there's a significant impact and cost on the workforce, so both to clinicians, staff, consumers, people in our care. This is sadly what an inexperienced workforce leads to. We have clinical and organisational risk, lower compliance, higher costs. You've got agency costs, you've got staffing issues, you've got hiring costs that you're trying to solve. We genuinely have higher costs because of a decline in workforce experience. We have service viability implications. You know, an unstable workforce. We're not able to confidently map out the next year or so of what we want to do as a service because of our workforce, you know, viability. We have potential harm, And we have the prevalence of high impact, high prevalent events, which I'm going to focus on a little bit more here. For our aged care friends, these are specifically called out in Standard 5 of the Strengthened Standards as something to avoid. So a high impact, high prevalent event is a situation or incident that occurs often. So it's high frequency or high prevalence, and it has a significant consequence for the person or the organisation that's involved with it. So if and when it happens, the severity of that clinical risk makes it high impact. Here are some examples. They're not black swan events. They happen frequently. Choking and swallowing issues, incontinence-associated dermatitis, falls, deterioration of oral health is a high frequent or high prevalent, high impact event. Aggressive or violent behaviour. These can result in genuine harm to older people, to anyone within our service, and pose a risk to an organisation. If you take an older adult, for example, that has typically frailty and multiple chronic comorbidities, look at the impact. These incremental decline and deviation from best practice leading to high impact, high prevalent events genuinely cause harm, and it's preventable. We see distress, we see a reduction in quality of life, we see someone that gets put on new medicines, putting them at risk of polypharmacy and medicines related events that didn't previously need to be on that medicine, and unavoidable transitions of care, so to emergency departments, hospitalizations, and of course cost. Why are they so concerning? Why are high prevalent, high impact events so concerning? And the reason is that they may be normalized. Because of their frequency, they may be normalized because we see them. And this is where I think things can spiral a little bit. Just put yourself in the shoes of a new staff member, maybe a novice early career clinician, or someone that's just new to your organisation at the beginning of their career. What if they see an event such as a fall, incontinence-associated dermatitis, medication incident occurring constantly? What are they going to think? They're going to think that the clinical care risk that they're seeing, it's inevitable, it happens. And so we get that deviation from best practice validated. And when they remain in an environment where better practice options are actually reduced, then this belief that the activity or the incident is normal, that substandard care is our level of our standard of care, it gets exacerbated. So we see that the incremental decline itself is unfortunately normalized over time, exacerbating the situation. So the factors compound, and the very systems, the processes, the cultures that we create that are designed to provide excellence in care are eroded over time. I'm very passionate about this topic. I wrote a much longer article than what I've shared, and encourage you to check it out. Sign up to the toolbox, of course, to get access to it. But I warned you, it's pretty grim, right? There's no kind of sugarcoating that part of the presentation. The sad reality is that, if we are to solve this problem, we need to call out the problem. We need to show how much workforce pressures or the experience complexity gap actually impact a care organisation in aged care or healthcare. So I will move into solutions mode now, but I thank you for bearing with me while we really unpack and try and get to the bottom of the problem. So when we think about workforce capability, what's the goal? What are we trying to do? And I think if you're lucky enough to have experienced leaders, experienced clinicians that are still providing care, providing stewardship at your organisations, then they will agree. This isn't a superficial answer. There isn't a quick fix, but we can make inroads, right? So we want to firstly reject the normalisation of poor care. We want to combat incremental decline. And we particularly want to close or narrow the experience complexity gap. And there are some ways that we can do it through training and education. But essentially, what we want to be able to do is to enable the workforce to work competently to the full scope of their practice. how we want to visualize this is that, remember, our top line, our orange, is the complexity of care, the standard of care that we need to meet. We want to bring our experience and our workforce capability up to the required amount. All right, we want to close or narrow the experience complexity gap. And how do we do it? We build workforce capability, right? So that is how, I make a strong argument today by saying, and I will say hand on heart, that building workforce capability is perhaps the antidote. It may not, maybe it alleviates it, maybe it fully doesn't fix it, but building workforce capability is how we can alleviate these workforce pressures. If we look at the definition of workforce capability, it refers to the knowledge, skills, attitudes, and competencies that enable staff to perform effectively in their role. Now, the benefits to building workforce capability is that we acknowledge that the entire workforce needs our support, right? The entire workforce, the growth, the opportunities, the enablement needs to be spread across the workforce, not just our bright stars, our novice, young, early career entrants that, particularly in acute care, we focus, I think it's 2/3 of hospital learning budgets get put at the graduate entrant level. But what about the rest of the workforce, right? What about our experienced staff, 10 years plus if you're lucky, maintaining their tenure through investing in workforce capability, helping them feel valued so that they can transfer their knowledge to the novice and early career staff is just as important. Before we get into some specific solutions, I just want to plant this seed. If you're, in a position where you need to communicate this, there's a very clear regulatory responsibility now that sits with employers. So employers have become responsible for upskilling their workforce. There are new compliance obligations targeted to the employer, not the employee, yet they clearly describe the expectations of the employee. So the example on your screen here is from, I think it's standard 1 of the strengthened aged care standards. Now, I know I'm talking a lot about aged care standards. They're the most recent piece of regulation that we can use, that we can point example that we can use. The NSQHS standards should be due for review next year. So maybe this time next year, we're keeping on referring back to the NSQHS standards. But, if we want to look at the trends of regulation and where things are going, the aged care quality standards and the strengthened versions are really good. So, what you're seeing here is possibly as a result of aged care being largely comprised of an unregulated workforce, the unregulated healthcare worker, whereas in acute care we have, AFRA and National Board regulated healthcare professionals that are regulated more so than the unregulated workforce, that's made up of about 80%. If we look at it visually though, think about employee capability regulated through the employer, right? So starting at the top here, you can see that we have a Quality and Safety Commission. So that's our top regulator. We then have the provider organisation and the workforce that sits in it, coming down to the consumer. So that's our flow of regulation, right? So quality and safety standards, directing how the provider needs to establish their organisation, and then impacting the workforce and, of course, the consumer. Got another visual just to try and picture this. If you imagine your quality standards, they outline worker expectation, and they state that the provider is made responsible and that the worker gets training and support from the provider. So the standards want to influence and impact and make sure that the employee has the capability, but they need to do that via the provider in a sector like aged care that is unregulated. There's not a National Board of Care Workers that's regulated that they can pass on that regulation to. So, summarised as the worker's capability is being regulated by proxy through the provider, but our quality standards are very much outlining the expectations around capability. And there's just one example. Your organisation must provide you, the staff member, with ongoing and training support regarding cultural safety and how this should be applied. So we've got quality standards directly saying this is the capability that you, the staff member, need, but it is your workforce that should provide that training. All right, so if we are to build workforce capability, how do we do it? Two things to get us started. I think firstly, it's the way we think, right? Acknowledging that compliance is critical, but it's not the end goal. We want to build a competent, a skilled, a capable workforce. That's our desired outcome, and particularly if an organisation wants to grow and scale. But literally, how do we do that? We create a capability-based L&D strategy. So how do we do that? Very briefly, and we're going to keep on talking about this next year. I recognise it's a massive, opportunity for us all to build these skills. But you're getting the quick flyby. How do we do it today? All right, 4 parts. I guess we can think of building creating and executing a capability-based strategy in 4 ways. The first, we want to assess the capabilities required, right? So we want to systematically identify what capabilities does our organisation need, and I'll show you in a moment. There are some shared sector-wide capability documents that come from the standards that set that sector level capabilities required. We, of course, want to then determine, well, what capabilities do we have within our organisation? What do we need? What does our organisation want to prioritise over the next year, 5 years, however long you set your strategy for? From there is where we get our targeted initiatives. So you notice I'm not saying targeted training, talking about targeted initiatives, because training isn't going to close all of our capability gaps. But target initiatives, thinking about it, only train when you need, right? Education isn't always needed, so use initiatives wisely. Identify the components of the capability. Is it a knowledge gap? It is a skill gap. Is it an attitude gap that actually needs a sit-down conversation, a performance conversation, rather than more training? Is it a policy and procedure gap? Systematically fill it. All right, what happens to mandatory training? Well, use it wisely. Use the mandatory training to specifically mitigate the organisational risks that are relevant to your organisation. And of course, we want to measure it. We want to measure success. I've got a nice diagram to kind of unpack that process, but I just wanted to share, a couple of key sector documents that are relevant. So in that first phase of assessing, what capabilities are required, there are some key shared sector documents that can guide us in terms of that direction. In terms of the NDIS, there's a NDIS Workforce Capability Framework that describes the knowledge, the attitudes, the skills expected of all workers that are funded under NDIS. Mentioning AFRA and the national boards, currently there are 15 capability documents relevant to the 15 national boards regulated by AFRA. But just in October, current consultation closed on consolidating these, and I put a response forward, a submission, really celebrating the efforts around this initiative. So the goal for acute care, the goal for registered health professionals is that there is one shared professional capability framework. And within aged care, there is the My Aged Care Quality Learning Framework. It was actually revised in February this year, and this document exists to ensure that there's an initial and ongoing quality and up-to-date training and continual development and verifications of the capabilities of the aged care workforce. So there are some key documents available that can help us assess what capabilities are required. Thinking back to the strategy and the 4 points, I'm going to walk you through the first 2 in a little bit more detail. So From the top down, as I mentioned, step one, we want to assess those capabilities required. And there's three, key places that we need to look to assess capability. I mentioned the shared professional capabilities. That was on the previous slide. Your organizational strategy is obviously key. What is your organization prioritizing? What are the goals? What are the strategic pillars that your organization wants to execute on over the next 1 to 3 years, whatever the cadence of setting is? And for acute care organization, your registration or accreditation standards, like your professional standards for registered nurse, etc., they also are valuable in assessing that capability if that workforce is relevant to you. From there, we want to conduct a capability assessment to determine, like a gap analysis, what capabilities do we need to develop? What do we have? Therefore, maybe we need to maintain, but not actively, place a lot of time and budget into. And, look at those prioritization skills. What are our high-risk capabilities that are missing? What do we want to fill? And from there, we get a very systematic grouping of capabilities, let's say by job role. All right, so the systematic grouping of key components is critical here. What I mean by that is that this process starts from top down. What's required? What do we need? What do we have? And what are our priorities based on higher levels of risk or per particular job role, let's say. I think systematically is the word to emphasize here, because remember, when we're talking about building capability, we're not just talking about assigning training or assigning learning. We are talking about a capability stack. So if I take the example of pressure injury care here, for an example, why is it a priority? Well, there's a quality indicator associated with it. It's something that multiple job roles may need to interface with, the particular capability. And there's harm to the person if it's not done right, and it costs, right? We know, think of the last dressing that you put on, it's probably between $30 and $100. And of course, cost to the person in terms of pain and necessary suffering. But if you're thinking about developing a pressure injury care capability, we need to be thinking about not just mandatory training, but understanding or ensuring that our policy and procedure aligns with the training. There may be some self-directed learning, toolbox updates, a component of skill acquisition, assessing competency, and then having that attitude or behavior. So just trying to help you visualize that we want to move from thinking about just providing training on a particular topic to thinking about what are our capabilities that we want to prioritize the development on, and can we think of building that capability in a stack, and thinking about, for particular capabilities, what mandatory training is needed, what competency assessment can help us verify that skill, what are our policies, procedures, relevant self-directed learning. So we're moving very much, but from just meeting basic compliance needs to building that capability. Why? Because we know that there are significant costs and harm associated with having an inexperienced workforce. We're trying to actively lift and build that experience of the workforce, and we're thinking about it as building workforce capability. Okay. Going pretty well for time, which is great, because I would love to have a discussion. I'm giving you the 5-minute warning that I would love to hear some comments, some questions and discussions. But just to emphasize, the importance of building workforce capability and thinking beyond compliance, I just want to share some practical things. Practical meaning, they take a lot of work and effort to develop, but they're non-training strategies, right? And I think this is really critical. Why are we talking about not just training? It's AusMed. We make mandatory training, we make education. Why are we talking about, doing other things? And that's because, training and education isn't going to solve all of our problems. Offering training, even education to someone with that existing skill or knowledge, it's a waste, right? It costs time, it costs money, and when it's used unnecessarily, we get training fatigue. So, I think I've said enough, but I just want to, as I said, end by sharing why we need to think about workforce capability and how we could do that. So, 5 non-training strategies. All right. To build workforce capability, you could consider measuring tenure as a core organisational metric. Measure with vigilance, either at an organisational global level and then, possibly even at a team, facility or job role. Why? Well, I know we've got many people and culture leaders on the call that I'm sure would agree. If we have less turnover from a higher tenure of existing staff, then we have less cost, less productivity loss, less impact on morale, less impact on culture, less onboarding costs, less loss of organizational knowledge. So there's so many benefits we know of retaining experienced staff, and think about it as $1 spent on retention is $2 saved on hiring. Second strategy, non-training strategy that you could consider that helps build workforce capability. Strategically distribute clinical expertise within your organization to reduce risk. All right. So how does that build workforce capability? Well, it is a zero cost knowledge transfer between experienced clinicians and your novice, early career or new staff. Better decision making. Teams may benefit from having access to a seasoned, experienced clinician that can guide complex decision making. Less errors, better care outcomes. And just recognizing that expertise that person has is valuable may in fact retain that talent as well. And then that's the confidence and capability. We all know, if you look at your team, if you think of your team and you've got good people in it, you feel confident, right? You're working with good people, they're experienced, and we know we can deliver on what we're being asked to do. Third non-training strategy to help build workforce capability is look at retaining experienced staff by offering mid-career opportunities. Now, I think this group is often forgetting. It's December the 10th. Oh my gosh. All the vocabulary, flies out the window at this time of the year. But I think this group is really forgotten. Interestingly, what is mid-career now? I would have said 5 years ago, 10 years ago, mid-career was maybe 10 or 15. I share the story of when Osmed used to run conferences and seminars. I worked in our events business and I would read every single evaluation. No joke. I read every time paper evaluations came back, I would sit down and I would read them. On the back of the evaluation form, it's all paper back then, we said, how was the food? How was the air conditioning? All, those surface level evaluation data, and of course, evaluated the education. But we would ask, how long have you worked in nursing for? How long have you been an RN, RM for? 20 years, 22 years, 27 years, 35. I think I saw a 44 or 47 once. Nowadays, if we did that same exercise, I think we'd be lucky to get, 5, 6, 7. So even thinking about what mid-career is, I think is interesting. But essentially, we know people will stay. People are retained beyond those initial, puff of energy that is invested in them. But people will, after, even if mid-career is now 2 or 3 years, if they can see growth, if they can see opportunity, if they can see progression through clear paths, then we're more likely to hold them. And one of the articles that we have on the toolbox, it talks about this, supporting the mid-career opportunity. And one of the examples was a mid-career sabbatical, which I thought was really interesting. It's not taking a year off. It is taking a year to go somewhere else in the organisation. Is there a project? Is there a new facility opening? What what is a way that we could offer someone in the midpoint of their career a sabbatical as such from the regular work that they're doing. So just planting the seed that, you know, there are a number of non-training and interesting, creative, even disruptive ways that we can support our mid-career workforce. Fourth strategy. Now this is, you know, I will happily be challenged that this is actually a training strategy. Yes, training may be involved in doing this, but thinking about if we want to build workforce capability, if you can visualize Benner's model of clinical competence, we start with a novice and we want to end at that proficient expert level. So we do need to think about how do we get someone who's novice up towards that competent, proficient expert level. Drawing on another example from St Vincent's, something Jade mentioned last week is that what St Vincent's, again, this is an acute care nursing specific example, but one that I wanted to share. What they're finding is that once a grad has finished doing their grad year, in their second year, they immediately preceptor students. So an interesting discussion that we could have about the pros and cons. We learn via example, right? So we want to make sure that the example being set is of the right standard. But a lot of organisations are seeing preceptor burnout. So staff at that experienced, expert, proficient level of Benner's model really just worn out from preceptoring and mentoring those novice nurses and novice clinicians. So that was an example of what St Vincent's are doing. But, you know, point is we want to move people actively and build their confidence. So moving from novice to proficient and expert, and thinking carefully and strategically about how we might do that. And I know I'm probably converting to the preaching to the converted here, but we of course want to grow our future leaders from within. There are so many benefits. You know, we know that imagine if an emerging leader arrives in a leadership position with built-in organizational knowledge, not hiring and have to orientate someone to your culture, but who has actively lived that. We know that growing from within means that a leader, now I don't mean executive, I don't mean, you know, CEO, it could be, you know, as someone, a care worker, it could be someone in your kitchen, it could be someone in admin, you know, this applies to everyone, that if they've worked in the role and they've progressed to where they are, they're going to have greater empathy. They've lived the experience that the people they're leading are going through, building, you know, their leadership credibility, building respect amongst their team. And we know it's costly, right? We know it's costly and risky when it comes to hiring for those leadership positions. If you get it wrong, which we sometimes do, then, you know, we can really impact our culture. So they were the 5 examples of non-training strategies, just to reinforce that, you know, our workforce capability is essential. It's essential that we think about not just building the knowledge and skills of our workforce, but actively thinking about how we're building the knowledge, skills, competence and attitudes of our workforce. So I warned you, I gave you the 5-minute heads up that I would love to hear comments, discussions, concerns. Open the mic up to you all. And I bet Michelle's got a question to kick off with.
Oh, you did not prep me on that one. But I, like Hayley, I was preceptive within the first 2 weeks of my graduate nursing year. I know, atrocious. I mean, I'm sure, Hayley, you were way better than me, but preceptorship did come very early, which was pretty insane. I remember in my first year, 2 new grads were put together and then we made a morphine error. So
Exactly.
Don't do that. That never happened afterwards. I don't have any questions for you. I think I'll leave a moment of silence to people watching to see if anyone had a question. I do want to go back really quickly to Nabila's question. I think earlier you were talking, Nabila, about, you know, how do we check kind of compliance and competency, if I've got that in a very short version back. And I think the answer is, well, actually my answer today is going to be, it depends on who you're wanting to prove it to. So if you're wanting to prove compliance or competency internally, then you probably want to look at your quality indicators. It doesn't really matter what people said or didn't say they learnt. If your falls numbers, if your wound numbers are out of control, then everyone can have passed all of their assessments all the time and demonstrated competence in their wound assessment competencies, and it's still not good enough. If you're talking about proving it to an auditor or an assessor, then and let's say they're a basic auditor, they probably are just want to look to see whether people have done it, irrelevant of whether they've learned it or hold the knowledge. So I would ask the question back to you, who are you trying to prove it to? So then you know which kind of line to go down. I love it when people don't use their names. So
educator admin at the Abbey. Reveal yourself. You've got a question.
Hi, yes, my name's a secret. Thank you for that. I really enjoyed that program. You mentioned a part about retention in staff briefly. I was wondering if you would ever do one of these sessions on that topic, how educating staff and training them properly can increase retention rates.
Absolutely. I'd love to do that. What's your name though? Or make up a name.
A secret. It was a beautiful name.
Secret. Hello, secret.
Secret. And it's a secret.
It's a secret. Absolutely. I think one of my biggest passions in education is evaluation, right? If you think about what's in the word evaluation, it's value. And I think we as L&D teams, people and culture teams, we need to be evaluating the impact of what we do to then demonstrate the value that education and also educators, L&D people bring. So absolutely, I think I asked this at a question at a conference on Friday about a preceptor program. What are your metrics? How are you measuring? Is it successful? Is it leading to retention? They couldn't give me an answer about this specific program, but I will go on a quest to look at how we can link education with some really strong research, but also some data and practical things, right? It's got to come down to, can you actually, do that within your organization? So absolutely, let's look at how education impacts retention, and you'll see us do something on that next year. Educator admin at the Abbey. Any other questions? 1:59 Melbourne time. Yes, Casey, absolutely. We'll send a recording out as soon as it's prepped, probably by tomorrow lunchtime, and we'll include the slides. Hello, Catherine. How are you?
I'm good. How are you? Thank you, Zoe, for that. It was a really interesting presentation, high-level stuff, which I think most of us are all aware of. One of the particular nuances that we're finding, having been in the aged care sector now for over 20 years and in health for longer, is what we're noticing in the workforce is the international RN cohort. And I'm not sure if we've got it. I know it's cross-sector as well, but what we're seeing with the international RN cohort or the international cohort workforce is some of those cultural nuances and how strongly embedded they are into our cultural workforce, and the challenges that presents. And I think that's something that the industry hasn't quite addressed or supported the workforce, especially in terms of developing capability, but also understanding cultural processes, values, beliefs, and how that impacts the workforce, and also the differences in the qualifications. So an internationally trained RN and how that varies in terms of skill mix in certain countries to the Australian qualifications. So I think it's very complex. It's multifactorial. I think it's not just around the black and white, structural frameworks and things. I think we need to really look a bit broader and deeper into that to really make sure that we're covering off some of these other factors as well. Just wanted to share that, put that out there.
I totally agree. And I think, Lisa, Catherine, and most others will agree that you're absolutely right. It is complex, but it is absolutely okay to call that out and to say this is a big challenge that we're facing. And I think, even thinking about it at a very granular level of just knowledge transfer, transferring knowledge from one person to the other. There's a barrier with even that basic, transfer. So let alone at skill level, at cultural level, at, building organizational capacity, it is challenging. Any other final comments or questions for us?
A minute and 48 over, Zoe. We're docking that from your pay.
All right, well, we'll leave it there. I hope you all have a wonderful rest of the end of year. I hope you all get some much needed time off. Thank you all for your participation. We appreciate, especially those that have joined us for the webinar series. We'll send the recording with the slides out tomorrow and look forward to seeing you in the new year. Have a great break, and thanks again, everyone.
Bye, folks.
Bye-bye. Thank you.